A warm welcome to each of you for joining us today for the Emirates Cardiac Society Journal Club, brought to you by the Imaging Working Group of the Emirates Cardiac Society. Whether you're tuning in from the Middle East, the UK, or from the United States, we are thrilled to have you all with us. I am confident you will gain valuable insights from our incredible lineup of speakers. We've put together an hour that promises to be both exciting and informative, and I am confident you will find it worth your time. I am Firas Al-Badareen. I'm a cardiologist from Cleveland Clinic, Abu Dhabi, and I have the pleasure of leading the Imaging Working Group of Emirates Cardiac Society. I'm thrilled to co-moderate this session with my friend and colleague, Dr. Mazen Hanna from Cleveland Clinic, Ohio, where he also co-leads the Amyloidosis Center. Mazen?
Thank you, Firas, and thanks for everybody joining in. As you all probably know, this is an exploding field. Therapies for transthyretin cardiac amyloidosis were absent a decade ago. Now we have tafamidis and then two other potential medications in the pipeline for potential approval within the next year, acoramidis and vutrisiran. And we're really blessed to have both Dr. Mariana Fontana and Dr. Ahmed Mesri to go over each one of the trials. So Dr. Mariana Fontana is a professor of cardiology and an honorary consultant at the National Amyloidosis Center in London, and a world leader in the field of cardiac MRI and in amyloidosis, and the first author of the HELIOS-B trial testing vutrisiran and transthyretin amyloidosis with cardiomyopathy. So Mariana, we really appreciate you joining us to take a deep dive into this clinical trial and go over the details and the results. Thank you.
Thank you very much for the very kind introduction, and thank you very much for this invitation to be here today. I'm very happy to present the primary results from the HELIOS-B trial, a phase 3 study of vutrisiran in patients with transthyretin amyloidosis with cardiomyopathy. These were presented at the ESC, and then the full primary results were then published in the New England Journal of Medicine. So, ATTR cardiomyopathy results from the accumulation of wild-type of variant TTR amyloid fibrils within the myocardium and leads to progressive heart failure, arrhythmias, and is also associated with a decline in functional status and quality of life, and a significant increase in hospitalization and reduced survival. With the recent advances that we've seen in diagnostic and treatment strategies, so we have seen really an evolution towards early diagnosis and improved heart failure management. And this has led to a contemporary patients populations with less advanced disease and patients also who are better managed from a heart failure point of view, but also from a disease modifying treatment point of view, because now got tafamidis available for all patients. So the HELIOS-B study evaluated vutrisiran, so a subcutaneously administered RNA interferon therapeutic, which is given every 3 months by subcutaneous injection, and which prevents the hepatic production of TTR, and this leads to a rapid and deep reduction in the circulating TTR levels. And the objective of the HELIOS-B study were really to establish the efficacy and safety of vutrisiran in a contemporary population of patients with ATTR cardiomyopathy. So the HELIOS-B study was a randomized double-blind placebo-controlled trial in patients with ATTR cardiomyopathy. So the study recruited patients with wild-type or hereditary TTR amyloidosis for a total of 655 patients, and these were randomized 1-to-1 to receive vutrisiran or placebo. There were two pre-specified populations: the overall population, which included all the patients in the trial, and the monotherapy population, which included only patients not on tafamidis baseline. There was a primary endpoint of composite outcome of all-cause mortality and recurrent cardiovascular events during the double-blind period of 33 to 36 months, and there was the fourth secondary endpoint, which included the change from baseline to 30 months in the 6-minute walking test, KCCQ, all-cause mortality of 42 months, and change from baseline to month 30 in NYJ class. Both the primary endpoint and the secondary endpoint were tested in both the overall population and monotherapy population for a total of 10 endpoints, 2 primary and 8 secondary. At the end of the double-blind period, patients were eligible to enter the open-label extension where every patient received the drug. So the baseline characteristics were well matched across the treatment arms, as you can see here on the left. But 2 points of worth noting is that first, there was a substantial use of effective background medication. So tafamidis baseline was 40% in both arms. And you can also see a significant drop in on monotherapy population. But there was also a significant use of other heart failure medication, which we know are very effective in this population, such as SGLT2 inhibitors. Also, overall, the population was a milder population compared to previous trial. And this is in keeping with what we also see in clinical practice, where the advances in diagnostic have led to a patient population which has got milder disease compared to previous trial. And so this one is a contemporary patients population, both in as concerned disease phenotype, so earlier than previous trial, but also the high use of background medications. So HELIOS-B met all the 10 endpoints in the overall population, the monotherapy population, so 2 primary endpoints and 8 secondary endpoints. And so in terms of primary endpoint, the trial reached statistically significant reduction in the composite of all-cause mortality and recurrent cardiovascular events, with a 28% reduction in the overall population. In the overall population, importantly, there was also a nominally significant effect on both components of the primary endpoint. And importantly, there was a similar contribution to the composite endpoint from both components of the primary endpoint. So with a similar effect on all-cause mortality and also recurrent CV events. In terms of the overall population, overall mortality through 42 months was also a pre-specified secondary endpoint. And again, the HELIOS-B trial reached a statistically significant reduction in all-cause mortality with a 30% reduction in the overall population. But importantly, there was consistent benefit across all pre-specified subgroups in both the composite outcome of all-cause mortality and recurrent cardiovascular events, as shown on the left, and also on the secondary endpoint of all-cause mortality through 42 months, as shown on the right. But 2 points are worth noting is that first, there was a trend towards great benefit in patients with earlier disease, so age less than 75 and NT-proBNP less than 2,000 nanogram per liter, with a 46 and 48% reduction respectively in the primary composite endpoint and a 45 and 65% reduction respectively in the all-cause mortality. But secondly, there was also evidence of consistent benefit in patients with or without tafamidis, so supporting the concept of an added benefit of vutrisiran on top of tafamidis. When we look at the monotherapy population, there was also the population who at baseline were not on tafamidis. There was evidence of statistically significant outcome with a 33% reduction in the primary composite endpoint, as shown on the left, and a 35% reduction in all-cause mortality, as shown on the right. So again, in keeping with a consistent effect across all the pre-specified subgroup analysis. So in terms of again, the tafamidis subgroup, there were favorable trends in the baseline tafamidis subgroup on both the primary composite endpoint with a 22% reduction, as shown on the left, and all-cause mortality with a 41% reduction, as shown on the right. So whilst there was a favorable trend, these didn't reach statistical significance. However, we need to keep in mind that the study was not powered to show a statistically significant reduction in this patient population, in this subgroup of the study. In terms of other secondary outcomes, favorable impact was seen across multiple measures of disease progression. So you can see on the left the 6-minute walking test and KCCQ, where the least square mean difference was statistically significant for both the 6-minute walking test and the KCCQ. Specifically with a 26.46 meter difference for the 6-minute walking test at 30 months and a 5.8 point difference for the KCCQ at 30 months. So, but when we calculate the least square mean difference, what we do is that we impute for missing values for death or for patients who progress. But actually, when we looked at the median change over time, which just takes into account observed values in surviving patients, you can actually see that for both the 6-minute walking test and the KCCQ, there is evidence of stability in the vutrisiran arm as compared to placebo, where there is a steady decline. In terms of biomarkers, when we look at NT-proBNP, which is a well-established cardiac biomarker prognostic of mortality in ATTR cardiomyopathy, there was evidence of maintained relative stability in NT-proBNP levels compared to placebo for both the overall population, as shown on the left, and the monotherapy population, as shown on the right. And in terms of safety profile, vutrisiran was well tolerated with a safety profile which was very reassuring for patients, with the majority of AEs being mild or moderate. No AEs seen more frequently in the vutrisiran compared to placebo, and cardiac AEs were similar or lower with vutrisiran compared with placebo. So overall, the vutrisiran safety profile was consistent with what we previously known from the HELIOS-A trial and from post-marketing authorization data. So in conclusion, vutrisiran achieved statistical significance on primary and all secondary endpoints with a reduction of cause mortality and recurrent cardiovascular events in a contemporary population of patients with ATTR-CM, which also included substantial background medications. And there was demonstration of significant benefit on multiple clinical measures of disease progression as well as NT-proBNP, and the results were consistent across all pre-specified subgroup analyses. And all of these was seen with a very acceptable safety profile. And overall, the results of the trial suggest that if approved, vutrisiran has the potential to become a standard of care for newly diagnosed patients, but also for those progressing or stabilizing therapy. So it could be a choice for first line, but also second line. And of course, we would like to thank the patients, the families, the investigators, the study staff, and collaborators for their participation in the HELIOS-B study, because otherwise this wouldn't really have been possible. And as mentioned at the beginning, the study has been published with full details in the New England Journal of Medicine, where you will find a focus manuscript on the primary results, which I just presented. Thank you very much for the attention.
Thank you, Mariana. That was a wonderful review, and congratulations on, that publication and help run the trial. I think that the take-home message for me is that suppressing TTR production with vutrisiran is effective and safe. And this particular trial, what was really interesting to me, above and beyond the mortality benefit and the decreased hospitalizations, is that when you use the observed values, there was really stability of the 6-minute walk in the KCCQ. I mean, if you look at ATTR and attribute, even treated patients at 30 months had a decrease of 60 to 80 meters in their 6-minute walk. So this was really encouraging. And not only that, the NT-proBNP. Can you comment on, were you surprised to see when we looked at the 6-minute walk in the KCCQ in this progressive disease that treated patients were basically stable?
I mean, as you said, I kind of was surprised in a good way, because was I going to expect that once you start a gene silence, and then you see complete stability on really parameters which matter to patients like the functional capacity and quality of life? Probably not, in the sense I could have even expected a bit of decline. But this is great for patients, and also for me, is both the stability, but also how early you can see a treatment effect on functional capacity and quality of life, because this is a question we got a lot after the presentation of the results, how early you can see starting the treatment effect. And when we look at the functional capacity and quality of life, is really almost the first assessment after really the baseline assessment. So I was pleasantly surprised, it's fair to say. And this is, of course, a combination of all the changes also that happen in these patients' populations. Now we treat patients earlier. we treat them with very effective background medications. And also for me, one important point was the suggestion of an added benefit on top of the families, because the future is really like, should we use combination therapy with a stabilizer and a gene silencer? In the sense, how can we achieve the best outcome to patients when we think about having all the possible drugs that hopefully will be available for our patients? So for me, what you mentioned about the incredible stability on the drug, but also the possible concept of, is it really combination what we should go for me were really kind of important findings.
Yeah, and that's a good segue. That I was going to, very important issue is, will this medication be a combination with tafamidis or a first-line therapy, or do you switch if somebody's progressing? I think that's what's on everybody's minds who's tuning in. You showed, about 130 patients in each arm were on baseline tafamidis, so 40%. And you showed the trends towards benefit when combination therapy, when patients were already on tafamidis and vutrisiran was added, there was a trend, although not statistically significant, for benefit. And I guess the question I have for you is, in this less sick population, if you had longer follow-up or more patients who were on combination therapy, do you think that trend could actually be significant? Because that's what's on everybody's mind.
Yeah, absolutely. I totally completely agree with you. The open label extension data will be extremely useful to actually give us more evidence on the effect of combination. Because even though the patients, also the placebo will go in the open label extension, we know there's a delay on certain outcomes, like, for example, mortality. So that could definitely become significant. It could just be a matter of having more events. But in the sense, the point is also, there was absolutely no evidence of heterogeneity. So this was not powered, but the lack of heterogeneity can make us safely assume that actually there is an added benefit on top of the tafamidis. I mean, I never really thought about it. When we think about the heart failure medications, SGLT2 inhibitors, MRAs, beta blockers, ACE inhibitors, they've never been tested on top of each other. But it was just the lack of heterogeneity of the treatment effect in each of the trial, where each drug was tested against placebo, that made us assume that actually the benefit will be added if we add them on top of each other. And now we use all the heart failure medications together. So if we translate this approach in amyloid, then we should really think about combining this treatment for the very simple reasons why we are using beta blockers, ACE inhibitors, MRAs, SGLT2 within the same patient. So, I mean, I agree, more data will support this concept, but I'm absolutely convinced that, as you say, this is just a matter of having more events. And I'm sure that the data will be strongly there, suggesting that combination is really the way forward in this population.
Yeah, I appreciate your comments. I think it's of course going to be controversial, particularly given the cost of these medications. The concept of knocking down the protein, if you really knocked it low enough, do you still need a stabilizer? I think one thing that we have to remember is the median drop knockdown of TTR was in the low 80s. So this drug does not knock down the protein completely. And if that's the median, then you have some patients who are knocking it down less than that. And so, but this concept of using them in combination does make sense. The question is, is that going to be something that's affordable? And Ahmad, if you don't mind chiming in on this whole question of when this drug becomes available, are you going to consider combination therapy, or are you going to switch, or how are you going to make decisions a year from now?
Yeah, I mean, just to take a step back, we're fortunate and we're lucky that we have options. We just wish that they're cheaper options, but aside from the financial toxicity aspect, we're lucky. Just where we were 8 years ago and where we are now. I think the question becomes then, who do you feel the burden of the proof lies on? And If you feel that this is a progressive disease, if the time when it's 3 years later until you get some more evidence is time you lost, then you could do, if you want, combination therapy. Myself, I'm more in line with the idea that if I use a medication, I need to know, aside from the outcomes, are we influencing something biologically, and we're very clear about what's happening there. There is a slippery slope here where tafamidis and acoramidis truly have very few, if any, side effects. The only thing to watch out for tafamidis is that if you use a very high dose of rosuvastatin, some extremely rare, but some patients can get rhabdo-like picture. Aside from that, I don't think I've ever seen anything else that someone comes and says, And so that's a slippery slope, correct? Because what's going to happen is we say that let's do this, and suddenly you have 50,000 patients, at least in the United States, I would say, on let's say both therapies, and I still don't know if when you use a drug like vutrisiran, which on average knocks down your TTR about 80%, and the knockdown is so tight that you see your confidence intervals around that is plus minus something 10, 15. So it's not, you don't have some patients who get knocked down 10% and some patients who got knocked down 100%. It's actually pretty stable across patients. So when we do that, do we believe that using a drug like tafamidis, for example, that would stabilize about 2/3 of your TTR or occupies 2/3 of your TTR in a stabilized way, when you cannot even detect using the clinical measures that we have, the circulating TTR itself as a tetramer? That's where I struggle. And I would like more evidence for that before I make this my practice. However, there are exceptions. We have patients with aggressive forms of disease. Those are not the common ones that are going to be, saying if I see them every day. I think we have less than 2-3% of the whole practice like that. They seem to still sometimes progress. They still to seem sometimes have some neuropathy symptoms, even when they are on a silencer. And those patients, yes, we try them sometimes on combination therapy. But outside of that, the wild type, for example, it does seem like the wild type, you might not need total suppression. Now, we've never tested this theory in humans, and Mariana and others and you and everybody on the call are helping us actually get there with this ongoing trial called Magnitude. And so with Magnitude, it's going to be the first time, at least to my knowledge, in humans, we were able to push the TTR knockdown suppression to levels beyond 90%, 95%, not necessarily in every single patient, but that's on average, essentially, or like in general. And so that's what's going to teach us the significance of this degree of knockdown, what's going to happen to stabilization or whatnot. I know it's a long answer, but I just wanted to be careful that it's not about that one should not do it necessarily universally. It's about where you stand on the data aspect and where you stand on the fact that you might be giving a medication that is not doing anything. And that's where I struggle a little bit.
If I can comment on that, I completely agree with you, Hamad, that there is a big difference between stabilizer and silencer, i.e. being able to measure the TTR levels in the patients in an individual level and say, oh, actually, I've given you this drug and I can check that the drug is doing exactly what it's supposed to do because I'm getting a knockdown of 80%. So it gives you that confidence that that drug is working with that individual patients that you've got in front of you, which is something that you can't really do with stabilizer in the sense that the levels go up, but how much up is up and how much up is enough? I don't think we have an answer there. So it's something that seems small, but actually from a patient and physician point of view, being able to measure that specific pathway and say, well, I've given you this drug and the drug is working, I think it makes a big difference.
Can I ask a question along the same lines? If you look at the Kaplan-Meier curves in Attract and in Helios-B, the mortality curve started to separate roughly around the same time, about 18 months or so. So first, were you surprised with that finding? Second, how do you explain that they start to separate around the same time when the mechanisms are different?
Yes, I mean, you cannot imagine the amount of questions that I got on this topic after the presentation, because everybody was really focused on that. And so, of course, the first thing is that the populations were very different. The trunk was very sick, and this one is much milder. And here there was a lot of use of background medications, and then, of course, there wasn't. So that's the first thing. The second thing is that you're not going to see separation of the curves until you have enough events. So comparing the Attr separation with the separation of these curves is very complicated, because you had a lot of events in the Attr trial, and here you had much less events. So you wouldn't start to see separation until you get enough events to actually being able to see separation. The severity of the patients also has got a lot of impact on when the curves are separate, because one could argue that if you have very sick patients, the first 12 months, those sick patients are going to die anyway. So that delayed the separation of the curves. So when for me, the answer that I found it more robust in terms of when do you really see a treatment effect is to look at the 6-minute walking test and actually KCCQ. And on those, you can see the treatment effect really starts straight away. So when you look at mortality, there are so many factors that kind of come into the equation, but most importantly is the fact that if you don't, in a new year where you've got less events, you're gonna see separation of the curves later, because of the number of events you're accumulating over time takes longer. I think it's very difficult to do a head-to-head trial comparison in that sense.
Yeah, and to Ahmed's point, you know, it's a good problem to have when this drug hopefully becomes available maybe next year, how we're going to implement it and in whom and whether we're going to use combination therapy is going to be something we're going to have to sort out. But I think that the discussion that you guys had about the degree of suppression and whether you really need a stabilizer if you're going to if you suppress it, let's say with CRISPR, with the NTLA 2001, with something like that powerful of suppression, do you need something else is going to be a question. I think it's super exciting. We really appreciate you spending your time with us going over the trial. And one last comment, just for people who are tuning in, pre-albumin, which many of you measure in your labs for nutritional status, that is actually transthyretin. Unfortunately, the name never changed from pre-albumin to transthyretin in the lab. So you can actually check a pre-albumin level on somebody on a silencer and see what the level, normal level is about 20 to 30. So if you start to 25, your assay may only say less than 3. It's not that precise. So when you guys were, Mariana, when you were talking about, I can measure the suppression, is that what you mean clinically by checking prealbumin levels?
Absolutely. Absolutely.
Okay.
And as you say, we were very surprised when we realized what you exactly mentioned, that we all measure in the hospital is not a new fancy assay. You just need to ask for an assay that has been there probably for 20 years. And so very cheap and available everywhere.
So when you check a level on somebody on Vutri, does your lab say less than 3? Is that the most that you can, like, what level are you looking for?
I think so. In our lab, I think we go down to 0.003. So it goes very low.
And Ahmed, are you checking those levels?
I do. I know there are different assays with different essentially quantification units as well. And there are different assays with different lower limit of detection. So if I remember correctly, ours essentially does not pick up anything below 3, was it milligram per deciliter? I don't remember exactly, but yeah, I think so. So it doesn't pick up below 3. So it's not as useful in this second generation silencers because it's almost everybody goes below that level. However, it's still interesting that we have certain patients who still have like a level of 5, 6, and 7, and they actually sometimes come back and complain of persistent sensory neuropathy symptoms. And so that's why we keep track of this But as Mariana mentioned, the academic question is more intriguing with the stabilizer rather than the silencers, because most of the silencers really get you to below 3 at our lab. And so there is not much to follow there except for the rare variants that are, difficult to handle.
Yeah, I appreciate that. And just remember for the viewers that when you start a stabilizer, the prealbumin level or the TTR level goes up. If you start a silencer, it's going to go down. Mariana, I know that you have to run. We're so grateful that you spent this time with us. Firas, do you have any other questions for Mariana before she?
No, I want to congratulate her again and her team, and thank you so much for your time with us on the call tonight.
No, thank you so much for giving me the chance to present these, of course, on behalf of all the fellow authors, and also thank you very much for accommodating the time. Thank you.
Absolutely.
Thank you, Mariana.
Thank you. Bye-bye.
Bye-bye.
Moving along, gives me great pleasure to introduce the second speaker tonight, Dr. Ahmed Masri, who's a close friend and colleague. Ahmed runs the amyloidosis and hypertrophic cardiomyopathy clinic in Portland, Oregon. And he has been heavily involved with landmark trials in amyloidosis, and I couldn't think of a better person to tell us about the ATTRibute-CM trial than Ahmed. So Ahmed, take it away.
Thank you, Firas. All right, so it's slightly different flavor from what Dr. Fontana was telling us about. This study been with us now for almost a year since its primary presentation, and just one second. And because of that, we have had lots of other analysis being published. So I'll walk you quickly through the primary results and then show you some, bits and pieces of these sub-analyses that were done, because I think they have lots of interesting ideas and factors amongst them. So these are my disclosures. This is called the ATTRibute-CM trial, which looked at acoramidis, which is a stabilizer, against placebo. Acoramidis is an extremely interesting compound because it was actually made to simulate what a naturally occurring mutation does. It's called T119M, and that's a super stabilizing mutation. So a very smart guy, happens actually to be Jordanian, was the scientific founder or / co-founder of the company, and he essentially, amongst others, used that mechanism to create this drug, which causes really strong bonds at a different site than tafamidis. So even this compound and tafamidis are within the same family. Their binding site and their energy use and their way that they stabilize the TTR tetramer is totally different. And so this trial looked at patients who have NYHA class 1 to 3, who had some heart failure, and light chain excluded, and randomized them 2-to-1 without tafamidis being allowed. So when the study was designed, tafamidis wasn't even approved in most countries, including the United States. And so you couldn't be on tafamidis for 12 months. You could start them after the 12 months. And this was a strategy to retain patients into the trial. That's why they were allowed to start it after. So it's a randomized trial. So baseline characteristics are going to be all well balanced. But the one thing that I want to share is that these are patients that are intermediate between ATTRACT patients and between Helios and B and others, because their NT-proBNP as a continuous variable is about 2,400. And so it's kind of in between that range. What's interesting is that all these trials have the same baseline 6-minute walk test, regardless of what they do when it comes to their inclusion-exclusion criteria. So these are the primary results, which you can see that so it looks like I'm missing a slide, but I can tell you the results without the slide. So the primary outcome was changed over time with the realization that there is a different event rate that is happening in 2022, 2023 compared to 2019 and 18 because of the different types of patients we enroll but also because of the treatments that we as physicians are providing to these patients and the seriousness of the disease, where you're going from diagnosis to treatment very short period of time compared to historical, where you could be living with the disease progressing for 3-4 years before you get enrolled in a trial. So this is the overall something called the win ratio. What's a win ratio? It's very simple. You essentially say, okay, I'm going to use mortality as my first tiebreaker. If a patient on the drug dies, that goes against the drug. If a patient on placebo dies, that goes against placebo. So you start counting your beans or coins there. Then once you finish counting the mortality, you go to heart failure, CV events. And so you count the same. But you, as you can imagine, you end up with lots of ties. So you need ways to break these ties, otherwise your trial will be negative. And so you go then to the third one, which is in this trial happens to be NT-proBNP. So who's winning? Is it the drug or is it the placebo? And then if the NT-proBNP doesn't break those ties, then you go down to 6-minute walk test as your fourth outcome. So it's a way to rank 4 endpoints, but by importance, which I don't think there is any discussion that mortality is the most important in heart failure hospitalization. So the trial was positive based on that. Another important metric is that 58 or 60% of the outcome is driven by mortality and CV events. So it's not like you're breaking 90% of your ties by 6-minute walk test or by NT-proBNP, which would have been not what you want. The majority of these events are driven by the hard endpoints that you would like. Then this is a forest plot. There is really nothing to see. It just shows you that the effect is consistent throughout all these patients. Remember, when you're looking at subgroupings, you don't necessarily worry about the confidence interval. What you would like to see is that the majority of the effect is towards the treatment side. Even if the confidence interval crosses 1, that's irrelevant because this is a subgroup underpowered assessment. So all-cause mortality was also different. However, it didn't achieve statistical significance. But this is completely mindless, you know. It might be more useful for like payers and all these people who are trying to like not pay for something. But for us as physicians, there was a 6% absolute risk difference, 25% relative risk difference. The families had 30% as a reminder, which is very close. And the p-value was something like 0.07 or whatever. So it's really irrelevant. If you added just 2 months or 3 months to this trial, for example, as follow-up, you would have for sure achieved statistical significance. This is again what we talked about. And what was very interesting emerging from this trial is that if you treat patients early, you get really significant reduction in heart failure hospitalizations. So 50% reduction, which has never been seen before, has not been replicated yet, actually, even. If you look at Attract, it was 30% reduction. And in Attract NYHA class 3, hospitalizations did not essentially necessarily get affected by tafamidis, even though it was a small subgroup. So chance findings are also possible there. But that essentially is encouraging for you that you actually need to find these patients early. And obviously, NT-proBNP, 6-minute walk test, everything went into the right direction. Also KCCQ, very robust stabilization, which is what we look at in terms of mean change in TTR level. As Mariana said, it's hard to know what every milligram means, but I'll show you some data that can help you understand that some more. These are interesting data. Very few of these trials show you how many improved in their NT-proBNP from baseline and how many improved in their essentially 6-minute walk test from baseline as well. And here you can see significant portion improved, even though on average everybody is declining, but significant portion still improved as well there. And the drug is well tolerated. There are no side effects or whatever, like you can attribute directly to the drug. So this is the bottom line. The drug worked very well. It achieved its primary endpoint, achieved the whole host of secondary endpoints as well. And we are seeing data that there are patients who are improving. And so we have to hone down and focus on this. So I want to show you some sub-analysis in the next few minutes. This is an intriguing one, and you should really think about this in your practice. This is a time to event analysis. We do the win ratio when we think we're not going to have enough events and when we want to power the trial better with a smaller number of patients. But here, just a traditional time to first event analysis shows you that within the first 3 to 4 months, you can start seeing an effect, mainly driven by heart failure hospitalizations, obviously, but still It's pretty impressive to see this over such a short period of time. So this old idea that TTR is such a chronic illness that 6 months, 12 months, 2 years is not going to make a difference in therapy is wrong. Actually, finding these patients early, instituting therapy as soon as possible is beneficial. Another interesting analysis we've done, which is if you get hospitalized or if you don't get hospitalized, what happened to your survival? And as you can imagine, if you are hospitalized on a therapy, or during a follow-up in the trial, you have a worse outcomes. So this addresses the point where some people come and say, hospitalization is a soft endpoint. I don't think it's that soft when the mortality difference, look at how different the mortality is. 87% in non-hospitalized versus 60% survival in hospitalized. That's a massive difference. Of course, it's not pre-specified, but still, it's as good of data as you can get to, honestly. And then this is to address the point that Mariana brought up. This is the first time that you look at this. Tafamidis never published this before, which is the probability of all-cause mortality on your y-axis and the change in serum TTR by just 1 month of therapy of acoramidis. And so if your TTR changes by +10, for example, which is, as we mentioned, was close to the average in the trial, you essentially have a probability of all-cause mortality to be on that 25% kind of reduction there, or it is a quarter of your whole range of all-cause mortality. If you get to the 20, which is not very common, it's a more rare event, your mortality is essentially near non-existent there. And you can see how tight the confidence interval is here. While if you're losing ground, and if you stay around the same at baseline, you're kind of almost average. But if you lose ground in terms of TTR, which we know is pre-albumin, it's also a holistic measure of what's going on also in the body. And so if you lose ground there, your mortality goes higher. So that's something that is of interest, obviously. How about if you look more at the change, essentially? So some people come and say, well, the trial allowed tafamidis after 1 year. So what happened? So what happened is only actually a small number of patients were initiated on tafamidis after 1 year. 15% in acoramidis and 23% in placebo arm were initiated. And then obviously the months of tafamidis initiation, 18 months versus 16 months. So really well into the trial. So it shouldn't have affected the outcomes that much because it was started later on. How about change in baseline serum TTR level? If you look at acoramidis only without tafamidis, it was 8, 9, and 9, while there was no change in placebo that much on average. And then what happens if we look at tafamidis? So acoramidis only was 9, tafamidis with placebo, very, very small subgroup, so be mindful of that, was 6. So look at the confidence interval here versus here. And then when we go into the open label phase and people switch essentially to continue to be on acoramidis, you can see how there is increase also in those both groups. And while all of this is statistically significant, the increase is on the order of 1 or 2 milligrams when we talk about this per deciliter. There was another study from also Mariana's group, a sub-study, looking at CMR in acoramidis versus placebo within the same trial. This is a sub-study, so only a smaller population. And as you can see, most things were in the right direction. So mass index reduction for acoramidis, stroke volume improved, LVF slightly improved, RVF slightly improved, ECV slightly increased, but not as much as an increase in the placebo. And then GLS stable versus worsening in placebo. And then, while overall the ECV, did not reach a point where you actually would like to see it, but regression did occur in 10% of the patients as defined by an ECV, more than 5% reduction there. So why are we talking about all of this stuff? If tafamidis solved all our problems in life, why do we care about finding newer therapies and doing more? It's because of this figure from the open label extension of Attribute, of Attract. So this is over 72 months. Not everyone was followed for 72 months, but over 72 months. Look at your ongoing tafamidis exposure curve. And instead of saying 50% survived at 60, 72 months, while the placebo to tafamidis 35% survived or something like that. Look at who did not survive in the tafamidis treated population. Almost 50% did not survive. And so that's important. And it's important because there's significant still unmet need, in my opinion, in the TTR space. You know, we might say that people have to die from something at the age of 78. That's true. But you have to remember something that everyone misses, I think, based on conversations that I have or conferences that I essentially, attend, is that we tend to compare these patients to the general population. These are some of the healthiest people that you will encounter in your life. They were all athletes, they were manual labor workers, they were very active. Their average BMIs are all 25 to 30 at most, if they're not in the normal range. Rarely you have a BMI above 30, 32 in someone with TTR. These are all people who don't essentially necessarily have really bad hypertension, diabetes, previous advanced chronic kidney disease, liver disease. So this is a healthier population than your average. And so that population, typically you should not, I think, be comparing them to your average 75-year-old who have a lot other comorbidities or who's obese or who's smoking and doing that other stuff. And then we did look at this also in our 5-center study from the United States. Dr. Hanna was also a major contributor to this study, where we just wanted to show you how things are different. So the black line here is the acoramidis line in attribute. The red line is the placebo line in attribute. The dark blue line is our patients in our 5 centers in the US getting tafamidis, and the light blue line is the attract tafamidis line. And then this is the attract placebo line. So our patients behaved as if they were in attract exactly. So these curves are overlapping. So we're not seeing necessarily that the mortality from these patients enrolled between 2018 and 2021 was very different from the attract patients that were enrolled from 2013, 14 to 2016, 17, something along these lines. I don't remember the exact dates for attract. But what I also wanted to show you is that look at the placebo in attribute. It's doing better than the treatment arm in attract. It's not because placebo cures people. It's because our patients are very different. And so making exact comparisons, cross-trial comparisons, are going to be problematic in this space. So just be mindful of that. So stronger stabilization appears to have a very favorable effect. Imaging sub-studies are useful because they can give you surrogates that you can't gain from just a 30-month trial. Study designs are very different, so be careful about cross-trial comparisons. And there is really, truly a massive ongoing need to assess the real-world outcomes and what's our unmet need in patients with TTR amyloidosis. Thank you.
Thank you so much, Ahmed. This was a great deep dive into attribute CM and all the sub-analyses. I have one question, and then I'll turn it over to Maz. If you go back to or if you recall the graph where you plotted the mortality against the change in TTR, what was the reference point? What was the hazard ratio calculated against? What was your reference group?
So you take essentially all the deaths that happen in the trial, and you look at mortality as a continuous variable. So you look at survival or mortality, whichever your interest is. So let's assume mortality for a second. And you plot the hazards as a continuous variable from the population. And so you do a continuous hazard exposure there. And then you take TTR change from baseline as your change metric. And so you are then looking at change from baseline for TTR and what happened to patients, not as counts, but as probability of survival or death throughout the trial. So it's more representative of the trial population doesn't necessarily 100% means that if you go and take 600 patients from the community, that the hazard of mortality as a continuous variable is going to be exactly the same, because it's a probability, and the probability is internally valid always. External validity has to do with how representative the patients we've enrolled to the patients in the community, and I think they're pretty representative. I mean, they don't have anything special going on with them compared to the ones we see in the clinic.
Thank you.
Yeah, I think you did a fantastic job. That was really a nice deep dive and showing us the sub-studies. You know, it's always interesting. You know, we've always said that a stabilizer will slow down progression. Best case scenarios, you know, keep things the same. And it was interesting that 10% and that MRI sub-study had ECV reduction that was significant. And that even in the echo, there was some improvement in the stroke volume index. What is your thought process about the pathophysiology of improvement with acoramidis?
Yeah, I think it depends where we capture you in the disease process. And so we see this frequently, even in clinical practice. If you present with an NT-proBNP of like 500, your NYHA class 1, you've never had a serious heart failure hospitalization, and you don't have advanced arrhythmias, and we just start you on a stabilizer, and we just like adjust the medication so that you're not on 200 of metoprolol. We see over the follow-up, the NT-proBNP goes down to 100, 150. We see essentially patients not progress. You know, I just saw a patient that has been following with us for 9 years. Same story, was just found early, and you know, was started on diflunisal very early on, but then switched to the tafamidis and has been doing the same. I think the pathophysiology has to do with the initial response. When you start having TTR accumulating in the myocardium, your initial response is myocyte hypertrophy, like any insult you would get in the heart. The myocytes can't multiplicate. And so their response typically to initial insult is almost always hypertrophy. And so you get the hypertrophy of the myocytes. You have little amount of TTR there, but you started your seeding process. With your seeding process ongoing, you're going to attract tons more TTR. That's why they fall off a cliff, correct? Because over a short period of time, your rate of accumulation is much faster than the first few, let's assume it's minutes, the first few minutes where you actually required a massive effort to get in there. Once you get in there, you know, it's like a Trojan horse, correct? Once you get in there, you get everything after easier. And so then the ongoing response is not myocyte hypertrophy. The ongoing response is subendocardial fibrosis and myocyte atrophy that eventually happens with ongoing and continued extracellular matrix expansion. So if you catch enough patients early on, I think the regression is not a true regression of transthyretin itself being removed necessarily. I think it's more or less probably related to the insult that have been going on. And once you stop these TTRs from coming in, your body mechanisms itself start taking care of some of these, you know, responses related to myocyte hypertrophy and atrophy and whatnot.
Very interesting. I will highlight one of the things you said is there's still an unmet need, right? So even this is an incredibly well-run trial, and yet, and at 30 months, even the acoramidis treated patients decline their 6-minute walk by 60 meters on average. You know, I think if anyone who's tuning in here, it's really important to diagnose these patients earlier and get them on treatment earlier for extensive amyloid deposition, whether the myocardium has occurred. But being NYHA3 should not dissuade one from using treatment, as Ahmed kind of pointed out. You know, I think that the likelihood that this drug is going to be approved is extremely high. We'll know by the end of November. And I hate to ask you this, Ahmed, but it's on everybody's mind as well. You're going to have 2 stabilizers available, I'm presuming, by 2025, with 2 different clinical trials, right? Attr median NT-proBNP was around 3,000. Here it was 2,200. 30% in Attr with the tafamidis study were NYHA3. Here I think it was 12% or something like that. So obviously we can't make complete comparisons, as you mentioned, but what is going to be your approach if you have two stabilizers on the market?
Yeah, great question. So there is a population that we already have that is fairly easy. They are progressing on tafamidis. They've had heart failure hospitalization on tafamidis. They are requiring more and more diuretics. Their GFR continues to decline at a rapid pace, and they're short of breath. And so that population, from my perspective, it's very simple. You know, if someone shows to the clinic and says, "I don't like how I feel on metoprolol," you could try bisoprolol or you could try carvedilol. You do that if they have HFrEF and a strong indication, for example, and you talk to them that, you know, this is really an important drug, I want to try that. I feel the same way about this. I don't know for a fact that acoramidis will be better than tafamidis 100%. But what I know is that the patient already have shown us that they're not doing, you know, all that great on tafamidis. Could a stronger stabilizer actually make a difference? And so those patients, I'm pretty certain that I've just switched them. Now, for the other patients, this is about like 1/3 of my practice. So for the other patients that are stable on tafamidis, I think, you know, it's going to be a hard argument to make that you want to switch them. However, you know, our patients who have TTR are very well read. They're very, you know, well educated about the disease process, about the treatment. So for the old ones and potentially for the new patients, especially, I will have just like an honest conversation with them. I would say, listen, we don't know which is better, and we don't know if these actually are any different. They both don't have major side effects. They're both are available. One, at least in theory and in the test tube and preclinically, looks so as a stronger stabilizer. It does increase the TTR level more, even though it's not head-to-head comparison whatsoever. Which one would you like to consider? And I think that shared decision making is important. And I think honestly, it's going to drive acoramidis utilization, because I think patients do think about these ideas and preclinical data as well as this mechanism of action of the drug.
Yeah, and you know, obviously, if vutrisiran gets approved in 2025, you know, we're going to have the enviable but difficult positions as clinicians to decide if you have a new diagnosis, whether you think you're going to just start vutrisiran as opposed to acoramidis or tafamidis, and whether or not you use combination therapy. I think, Ahmed, your comment that it's a good problem to have is completely true. I mean, the strides that we've made in this condition is, to me, just unbelievable. I literally just this morning saw somebody 7 years later, they were in the Attr cardiomyopathy trial. They turned out, when unblinded, that the patient was getting the drug for the 30 months, and he's got another 30 months. And over nearly 7 years, his NT-proBNP, which was around 800, is 600. And no diuretic changes and whatever. So 7 years, and this patient's survival, I think, could be a lot longer. So it's really an enviable position, and obviously we have a lot more work to do. Firas, do you have any other comments about the trajectory of the field and the ongoing studies with depleters? You're muted right now.
Sorry. No, thank you, Maz. I think it's an exciting time. You have 2 classes already with the studies underway or completed. You have several other classes that are being investigated, CRISPR-9, the depleters, and so on. So, good time to be in the field of cardiac amyloidosis. Good news coming to patients and to clinicians. So, as we get closer to 8 o'clock our time, noon for Maz, and 8 a.m. for Ahmed. I would like to thank you all for your time and valuable insight. Really, we present a lot of articles in Journal Club, but to present a New England Journal of Medicine, to present 2 articles, each presented by one of the main authors, is a true privilege. So we're very excited and thankful for all of you for your contribution and your thoughts.
Pleasure.
And with that, I would like to thank the speakers and the audience, and stay tuned for our next episode. Thank you so much.
Here.
Thank you.